Let us just go through with some of the definitions before, because I'll be using these terms a lot during the talk, and you should know because these definitions keep on changing over time, so we should be keeping up with the times and what are the currently accepted definitions. So new case, nothing much has changed. A person who has never taken treatment for TB or has taken TB drugs for less than a month. What is bacteriologically confirmed TB? So either it is smear positive, culture positive, or use of WHO accredited rapid diagnostic tests, which includes gene expert and other diagnostic molecular testing, which is approved by WHO. What is clinically diagnosed TB? A lot of clinicians diagnose TB without any evidence of bacteriological confirmation. But if a clinician decides to clinically, radiologically diagnose a tuberculosis patient and he decides to give the treatment for complete time, then WHO says you can call it clinically diagnosed. What is PTB, which involves lung parenchyma or tracheobronchial tree. So endobronchial tuberculosis is also type of pulmonary tuberculosis. And extensive pulmonary TB is the one which has bilateral cavitary disease or extensive parenchymal damage. What is extrapulmonary TB? Involving organs other than lungs and central airways, which is pleura, lymph nodes, abdomen, GI tract, skin, joints, bones, and meninges. And severe forms include miliary tuberculosis, TB meningitis, osteoarticular or spinal tuberculosis, or pericardial TB. The other definitions that you must know is drug susceptibility testing, whether you are using molecular or genotypic techniques to find out the drug resistance patterns, or phenotypic methods, which are the conventional methods of drug susceptibility testing. What is drug susceptible tuberculosis? A case of TB which is either clinically or bacteriologically confirmed without any evidence of resistance to rifampicin and isoniazid, or any other drug for that matter. Now, drug-resistant TB, they have broken it down now. TB resistance, TB disease which is caused by organisms resistant to any of the TB medicines is drug-resistant TB. Now, you have R-susceptible INH monoresistant TB, which is only resistant to INH. This category was not there earlier, but now INH resistance, primary INH resistance is also seen without the presence of rifampicin resistance. So, this has been added. Then there is RIF-resistant TB, where you have resistance to R. Patient may have resistance to H, or it may be susceptible to INH, and they can have resistance to other second-line drugs also. In this, they have subcategorization. You have MDR TB, which is resistant to R and INH both. You have pre-extensively drug-resistant or pre-XDR TB, which is resistance to R, and also may be resistant to INH, but at least to one of the fluoroquinolones, which form the part of group A medicines now. And the fluoroquinolones are levofloxacin and moxifloxacin. So pre-XDR, you have rifampicin and a fluoroquinolone resistance plus minus INH resistance. What is XDR TB? Again, resistance to R and fluoroquinolone and to one of the drugs from group A, which is group A only has 3 drugs. Now I'll show the classification of group A, the current classification of TB drugs. This is different from the classification that we used to study earlier. So now the WHO has updated it in 2019. Group A has only 3 drugs: fluoroquinolone or moxifloxacin, which is from the fluoroquinolone group, bedaquiline, and linezolid. So if you have XDR TB, levoflox was already a part of pre-XDR. So you have either left bedaquiline or linezolid, either of the two if they're resistant, then it is XDR TB along with R resistance. Group B has clofazimine and cycloserine or terazidone. And group C has all other drugs like delamanid, ethambutol, pyrazinamide. So these drugs have been categorized for management of drug-resistant tuberculosis. Now, what are the guidelines now which I'm going to talk about? The most latest is the WHO treatment update for drug-susceptible TB and drug-resistant TB. India last guideline update on drug-resistant TB came in 2021 March. Then we have drug-susceptible TB guidelines from India, which were last updated in 2020. The other guidelines that government has come up with, tuberculosis preventive therapy, which is a topic of contention. People are still debating whether it is to be done or not, but the guidelines have already been rolled out in 2021. And last is management of EPTB, which I'll not be able to cover because of the shortage of time, but I will just give you the overview of things. So how do we manage drug susceptible TB in India currently? it is very simple. Those 4 drugs are there, HRZE, 2 months of that and 4 months of HRE. So don't use HR. The continuation phase should also have HRE. And it is a daily dose. Do not give intermittent dosing or weekly, bi-weekly. Don't give therapies like that. The WHO and even the NTEP program India recommends fixed daily combinations of drugs. Don't give individualized drugs because that is more liable to abuse. So any patient who's been diagnosed in a government setup automatically goes to the NTEP center, which is government designated. Even for private practitioners, if you're notifying the patient to the government centers, they will get the drugs from there. A patient remains under follow-up with you, or you can start them on combi packs, which are FDCs. But preferred way is to enroll them into the government program. And always follow the appropriate weight bands. I say this because many patients gain weight during the course of treatment and we forget to revise their doses. So a patient who's 50 kg will be 3 tablets of a fixed dose combination initially, but as he gains weight and crosses 55 and reaches around 58, you can actually step it up to 4 doses, 4 tablets a day. So these are the doses which are well aware of: INH 5 mg, rifampicin 10 mg per kg, pyrazinamide 25, ethambutol 15. Then number of doses of tablets is also given as per NTEP. Now what is the update in drug-sensitive TB in December 2022? So it says that there is no change in the 6-month regimen of drug-susceptible TB. As I've already said, this is almost in line with what India is following, 2 HRZE plus 4 HRE. Okay? And then whenever it's feasible, you should give daily dosing. They are not recommending thrice weekly. FDCs are being preferred over other things. And if the patient remains sputum positive at the end of IP phase, they are not recommending to extend the extension of IP is not recommended. What you should do is look for drug-resistant tuberculosis and follow that algorithm now, right? Ideally, a patient in India, now the government is recommending to do ruling out resistance to rifampicin at the outset in every new case, not just patients who are failing the treatment. What is new? This is about HIV patients. Nothing much has been changed. They should receive the same duration of treatment as the normal tuberculosis patients, and ART should be started within 2 weeks of ATT, irrespective of the CD4 counts. Now the next is the new recommendation. The new recommendation is about the 4-month regimen. So some evidence has come up for shorter regimen for drug-sensitive TB. And they're saying the patients who are more than 12 years of age can receive 4 months regimen of isoniazid, rifapentin, moxifloxacin and pyrazinamide as 2 HPMZ and continuation phase of 2 months with HPM. Pyrazinamide is not included. Here the P stands for rifapentin. This is a conditional recommendation, moderate quality evidence. So now WHO in the entire global, there is a talk about shortening the ATT regimen for all the patients, not just for drug sensitive but for drug resistant TB also. So this is a step towards that, but India has not rolled out any such plan. As such, rifapentin is not really available in the program as of now. For children also, they are recommending in some children who do not have very extensive disease, a 4-month treatment regimen can be used. This is a strong recommendation for children, so pediatricians, probably IAP will change its guidelines based on that. Coming to drug-resistant TB, this is the PMDT program which was rolled out in India in 2012, and then it has progressed to the National Strategic Plan for Ending the Tuberculosis by 2025. Looks very far-fetched, I don't think so, but still we are moving and we are trying to add on to our initiatives how to end tuberculosis in India. Now, what is the current treatment of DRTB in India? You have 3 scenarios. This is the latest guidelines, Indian guidelines. I will come to the WHO update on that. So you had a polydrug resistant TB or H monoresistant TB, where rifampicin resistance was not detected, but INH was resistant. So they are saying that you give at least 6 months, or you can extend to 9 months of a non-rifampicin based, non-INH based regimen, and you replace INH with levofloxacin in this group. So this is a common scenario, and nowadays we are not only subjecting our patients to gene expert to rule out R, we are sending the samples to do genotyping by LPA method, and also INH resistance is being ruled out. Second is all MDR or RR-TB patients who have no prior history of drugs, who can be given a shorter regimen for MDR tuberculosis, which is oral. So now India rolled out use of any injectable long back. In 2021, the major change was not to use any second line injectable drugs. That is amikacin and kanamycin. They were not to be used. So now we are using only oral drugs. There are two regimens for that. One is the shorter regimen, all oral, and the second is longer regimen, all oral. So when do you use shorter regimen? When you do not have all these problems with the patient, no prior history of the drugs for more than 1 month, no resistance to fluoroquinolones, no extensive tuberculosis, as I have already said, extensive EPTB or extensive pulmonary tuberculosis, the definition has already been told, children less than 5 years, pregnancy in a patient and the gestation is less than 32 weeks, or a patient is lactating. All these things, if they are not present, you can consider your patient for shorter all oral regimen. Now, a shorter, you have 4 to 6 months of bedaquiline, levofloxacin, clofazimine, HE, and pyrazinamide, followed by 5 months of levofloxacin, clofazimine, pyrazinamide, and ethambutol. You have to give bedaquiline at least for 4 to 6 months, and you have to continue the rest of the drugs for the continuation phase. So the duration of the treatment would be somewhere around 9 months to 11 months based on the physician preference. If you have any of the exclusion criteria, you go for a longer all oral regimen, which is around 18 to 20 months still in Indian guidelines, and that is levofloxacin, bedaquiline, linezolid, clofazimine, and cycloserine. This combination is very difficult for patients. If you have any patients who are taking this, it is very difficult to pull on. Bedaquiline has to be given for 6 months, which patients are able to tolerate. The issue is with linezolid, clofazimine, and cycloserine. So clofazimine is a must drug in this, which causes a lot of red skin discoloration and very taxing for the patients. Linezolid-induced complications are very frequent. Patients develop pancytopenia, patients develop peripheral neurotoxicity, they will complain with numbness, tingling, all those complications will come up. So they said that after 3 months of linezolid, at least 2 continuous months of linezolid, and your patient is doing well, you can consider stepping down the dose to 300 mg OD. As it is, the dose of linezolid in these programs is 600 OD and not 600 BD, which we use for our infections and staph, right? So this is different. So what about bedaquiline? It has got new guidelines. Indian guidelines say that it is approved for ages more than 6 years when the weight is above 15 kgs. It can be used in pregnant and lactating women and those who have stable arrhythmias, and it can also be given for EPTB. So a lot of patients are nowadays being diagnosed with MDR-TB in lymph nodes. It is not very uncommon, but now bedaquiline as a therapy has been approved. For delaminate, again, age more than 6 years is all right with the Indian guidelines and requires no dose adjustments. And concurrent use of bedaquiline delaminate also under trials. Some very few advanced epic centers in India like NITRD, they are also using concurrent drugs but that is in only specialized settings. No physician is advised to write a combination of delaminate and bedaquiline as per the current guidelines. Now, what is the update by WHO? Very interestingly, I'll just talk about this new recommendation. Very, very difficult to actually digest what they have suggested. They are suggesting a 6-month regimen for drug-resistant tuberculosis. We have moved from 2 years of MDR treatment, which used to be like a curse on the patient. Now they are suggesting the use of 6 months of bedaquiline, pretomanid, linezolid, and moxifloxacin, which is B-PAL-M regimen. And they are saying that it is non-inferior to the ongoing 9-month all-oral regimen. Now, it suggests that you have to use bedaquiline in the prescribed doses, pretomanid, linezolid again 600 mg, and moxifloxacin rather than the 9-month or the longer 18-month regimen. It is a conditional recommendation and the evidence is still mounting. What other recommendation is, this is the preferred regimen as per the WHO, the 6-month regimen. The alternative regimen they're suggesting is 9-month all-oral, which we are already using in India. That 9-month all-oral regimen should be preferred over the longer all-oral 18-month regimen as per WHO. And you have ruled out fluoroquinolone resistance. So patient should not be a pre-XDR because the main basis of using shorter regimen is use of fluoroquinolones. What about 6-month regimen? It is a milestone, as it seems to be setting basis for the shortest ever all oral acceptable equitable patient-centered regimen. It is preferred over the BPAL, other BPAL regimens. So they had tried multiple BPAL regimens, including BPAL-M, simple BPAL. BPAL clofazamine was also tested. So BPAL-M was the one which was the best out of all the regimens, leading to most treatment successes, lesser failures or recurrences or drug resistance, and most tolerated in terms of adverse events. So it can be given regardless of HIV status, even in extensive forms of EPTB and pulmonary TB, except CNS, miliary, and osteoarticular involvement, and age less than 14 years, because the trials were not including these kind of patients. So this is based on the trial, TB practical trial, Xenex trial, and next trial. The residents must note these trials because these are the hot debate topics right now, and these are must know trials in tuberculosis, at least for now. And they have suggested that daily dose of 600 milligrams of linezolid is needed for at least 26 weeks, and it is better tolerated with no difference as compared to the dose of 1200, as I've already said. So these are the two trials, TB practical trial and Xenex trial, and how the trial have used the drugs and the doses have been given. So if you have to start this patient, the WHO suggests that you go for a drug susceptibility testing. Then you start the patient on an empiric drug regimen, which comprises bedaquiline, pretomanid 200 milligrams, linezolid 600 milligrams, and moxifloxacin 400. And then you also monitor the patient time to time with ECG, complete blood counts, liver function testing, and monthly clinical visits to the neurologist for assessment of clinical peripheral neuropathy. So linezolid, I have already said that enough data is there about side effects of linezolid, so keep the patient under close follow-up. Then the second is 9-month all-oral treatment, which India is already using. So now WHO has suggested two versions of it, the ethionomide variation and linezolid variation. And the duration of treatment, as I have discussed, is already the same, 4 to 6 months with bedaquiline, and then switch over to the residual drugs without any bedaquiline. And it can be given to children above 6 years, and pregnant and lactating women can also receive the linezolid variation because ethionomide is contraindicated in pregnancy. Again, this regimen is not for the severe forms of tuberculosis. So either in those patients you have to use the all-oral longer regimen only. So this is the difference between linezolid and ethionomide as far as side effects are concerned. Most common in linezolid is myelosuppression, peripheral neuropathy, lactic acidosis, and diarrhea. Very commonly seen all of these effects. And ethionomide mainly the GI side effects and hepatotoxicity. So they have compared in this table the different regimens and where it can be used. So what you can, now you have 3 regimens for drug-resistant tuberculosis as per WHO latest update, and you should individualize the patient on 3 regimens. And this is the preference order, the 6-month regimen, 9-month regimen, and all-oral longer regimen. But when we suggest such kind of a shorter regimen, what are the challenges? So the access to drug susceptibility testing. Everything lies on the fact that BPAL-M has a very low number of drugs. Only 4 drugs are suggested in BPAL-M regimen. So you can imagine if patient is inherently drug resistant to any of the drugs, the regimen is likely to fail. So drug susceptibility testing for all these drugs should be done prior and confirm that patient is susceptible to all 4 of the drugs, which is not possible right now because currently you do not have access to drug susceptibility testing for many of the drugs which are suggested, including pretomanid and bedaquiline and linezolid. So we are doing bedaquiline and linezolid in advanced centers in India. It is available, but pretomanid I don't think it is available in India as of now. The other thing is the cost of drug. Unless it comes to the program, in Indian program, we cannot as individual practitioners write these drugs anyways. I don't think we have access to bedaquiline, dilimanid also, forget about the newer regimen. And the choice and dose and duration of drugs is the data is still evolving. So they have shown it to be non-inferior to the already existing longer regimens, but the population that they had selected was very, very limited population. Comorbidities were not addressed, extensive forms of tuberculosis were not addressed, age less than 14 years was not addressed, so there are a lot of concerns regarding it. And the WHO has not given any order of replacement of drugs. Suppose your patient is resistant to one of the drugs in BPAL-M, so what are you going to replace it with? Whether it is cycloserine or clofazimine, what drug will you going to replace? So they have not given any directions on that. So it is still a challenge. This we already know, longer all-oral regimen for TB. It should have at least 4 drugs in the intensive phase. 3 from group A are a must. So group A, all 3 drugs has to be there, and at least 1 from group B, and then continuation phase of 3 drugs. And you can add from group C if your regimen is falling short of 4 drugs. And you know when to use longer regimen when your shorter regimens cannot be used, you have resistance to any of the key drugs, lack of response, drug intolerance in pregnant and lactating women. A couple of slides for the TPT, because this is a new thing. I've not gone into the depth of the TPT therapy, but India has highest burden of TB infection, and 5 to 10% of those infected will develop active TB in their lifetime within first 2 years of infection. And 70% of household contacts of PTB patient had baseline TB infection. They were having latent TB. By TB infection, I mean they had positive latent TBI by tests, which are TST, tuberculin skin testing, or IGRA testing. The risk of TBI increases almost by 20 times in cases of HIV co-infection, and eligibility for TPT relies on ruling out active disease and also ruling out risk versus benefit ratio. So this is what they have suggested, that rule out TB, and any patient who has been targeted for TPT should be started and followed up. What is the target population? So this is the guideline as per Indian government. The target population is people living with HIV, which includes adults and infants. The household contacts below 5 years of pulmonary tuberculosis patients, and household contacts 5 years above with pulmonary tuberculosis patients. In those patients, you have to give TPT after ruling out active disease. And the other group is patients on immunosuppressive therapy, silicosis, anti-TNF treatment is planned, or patient has been ongoing on dialysis, and patient has been planned for solid organ or bone marrow transplantation. In these patients, the preferred therapy is, first line is 6 months of daily isoniazid therapy, or you can replace with 3-month weekly isoniazid rifampicin therapy. So preferred is daily isoniazid, which is easily available. These are the contraindications where you don't have active TB or chronic hepatitis or any hepatotoxic drugs or heavy alcoholism problem. Adverse effects we know for all these drugs. And they also have rolled out, surprisingly, TPT in drug-resistant tuberculosis contacts also, which is difficult. What they are suggesting is use of 6 months of levofloxacin to be given as tuberculosis preventive therapy in patients of contacts of DRTB, or you can give 4 months of rifampicin daily, where the patient is sensitive for rifampicin and resistant for isoniazid. So these are the suggested reading WHO guidelines for PMDT, TPT guidelines, and EPTB I have not included because we had little time for this. So EPTB workflows have been, and this year only 2023, the operational guidelines for EPTB have been launched by Indian government. So all of you can access those guidelines. They are very nicely written, and very lot of flowcharts and diagrams have been included for ease of practice. Thank you.